Yeah, so I'm going to give you a quick presentation on the Access to Care portal and the HSE claim system. I just want to say that I don't mind giving up my spot to David, and I mean I was very happy to do so. All my jokes about kind of giving the presentation straight after lunch and people being fast asleep are just not going to work anymore, unfortunately. So we'll just kind of move on swiftly from that, if that's okay. Just by way of an agenda, we're going to talk about an introduction and an overview, and then like the overall referral process, and just to explain and just put the whole thing in context. There's a couple of different referral types. We've evolved the project over the last couple of years and a couple of different referral types. And then I'll talk about the software, some results, and the challenges that we've encountered, and then conclusions in the future as well. Now, I should say as well, to a certain extent, I'm kind of standing up here like a figurehead. I don't actually do any of this work. It's Joe, Pavel, Richie, Phil. They all do the work. Like I'm just stand up here and kind of claim all the credits. So they're the people who do all the work. In terms of the original project conception, it was really conceived to address a problem that was identified during the pandemic, and that was that the HSE did not have a national system for recording and paying for procured activity. Individual hospitals could do it, but the HSE as a national organisation couldn't do it. And so we were all gathered into a room and said, we need to sort this problem out. And what we did during the pandemic is we had to go to the NTPF to get it done, and we had to go to VHI to get it done. So we needed a system ourselves, and that's where this all originated from. And so there's two broad areas we've covered, and most of it is to do with access to care. And you'll hear me refer to something called the Access to Care portal, which is the main system involved, right? And so it's used for funding outsourcing initiatives, right? So that means public patients going to private hospitals or private vendors. And it's used for funding insourcing initiatives. That means patients going to public hospitals and being treated in public hospitals. And then there's this funding of waiting list management initiatives. So that's like DPS and ACP, where patients are being examined, their charts are being examined, and they might be moved forward without them actually going to a doctor. And in all this, as part of another part of this whole process is this whole concept of medical beds that was introduced as well. And it was extremely important when it came to the work around the winter initiative and things like that. All this is coming through the waiting list access plan, which is or action plan, which is being funded through the Department of Health. And this funding, all this work, is not in competition with the NTPF. This complements the NTPF. We make sure that we're not doing the same work as the NTPF. There's no point in us both doing the same thing. In addition to that, our colleagues from the National Women's and Infants Health Programme, who actually share a building with us as it happens, they actually came down to talk to us about it as well, because they had a problem that they needed to solve, and they heard that we could solve their problem for them. So I know there's a couple of them here as well, and I'm hoping they're still very happy with the system as well, right? So they obviously do a lot of work in fertility among a lot of other tasks that they do, but they had to provide services for public patients in the whole area of assisted human reproduction. And they needed a way of sending these patients out, referring these patients out, and then paying the actual vendors for the work that they do. And that fit exactly in our system as well. So we were able to expand it to do that as well. And once again, that's all activity funded by the Department of Health. In the overall system, there's a whole pile of key features or key kind of touchstones that we would describe it. The first thing is ease of use. That's what we've designed it to do. We don't want to be ringing people. We don't want to be getting phone calls every day from the users saying, how do I do this? How do we do that? So we keep it easy to use, as easy as possible to use. We don't make it complicated. It's flexible. We're able to make it flexible. We want it to work for people. So we make it flexible. We make it easy, so that whatever the problem is, we'll come up with a solution for it. It's expandable. It's very clear. By the end of this presentation, you'll see how we've expanded. We've gone from the surgical services to a whole pile of different types of referrals. Transparency is incredibly important. The center of this and reportable is further down this as well. We know the patient who's been sent, we know where they've been sent, we know what happened to them, we know how much it all costs, and we know when we paid them. It's all there. And the accountants in my life, they're all delighted with this because they can see all this information. It's auditable as well. We can then go back, and we have already been asked about individual things. Something doesn't work, or something doesn't, something's not gone wrong, but there's something that it just isn't right, and we can go back and we can see all the data. We can work it out, and we can work back to say we know what happened there. Reportable, I've already said. One of my colleagues spends a lot of his time creating reports because we're nearly too good at it, and the people who are looking for the reports say, well, we can always ask for more reports. It's connected. We've managed to connect it to the waiting list system. We've connected to IFMS. We connected to the predecessor of IFMS. The SAP system was there before that. And the final thing then is procurement compliant. That we have this as an underlying thing that we're not taking on any systems, we're not taking on any kind of processes that aren't backed up by procurement. We know we're happy from that point of view. The components of the system, we have a waiting list import system. Now, there's two of those, actually, because we have the IPDC, the inpatient day case waiting list, and the outpatient waiting list. We have the Access to Care portal. This is how we send the patients out from the public hospitals to the private hospitals, or to the public hospitals. We have the HSE claim system. That's the private vendors. That's how they submit the claim. They have to submit a claim. They have to tell us what happened to the patient, and they have to submit an invoice. We have a claims management system. That's how the people then will look at it. Most of them are done automatically. The patient is sent out. They're treated for what they're sent out for. We know how much it's going to be because we have it through the whole procurement arrangement. So if it comes back in with exactly the cost, if they submit an invoice with exactly the cost of what we expect it to be, it just gets paid. We don't look at it. And it's only the outliers we have to look at. We have a payment system. We then pay it. It goes through the IFMS. And we pay it. One of my colleagues operates that. And we have reporting across the whole lot of it. That's important as well. We are able to report on it. So one of the things we have to do now is we have to do accruals from an accounting point of view, so we know that patients are being sent out, so we know we're going to have a cost at some stage in the future. All this is developed by my software development colleagues in the HPO team with support and guidance from HSE Acutes and from EY, though EY are kind of stepping back to it from it to a certain extent. Just going on to the overall process then. So what we're talking about in the overall process is the patient is selected for referral. Now, depending on what you're being sent for, that means different things, right? So obviously, if the patient is going for assisted human reproduction, the reason that how they're selected is different to if it's just a general surgical services. And a record is created in every case in the Access to Care portal, and they get what's called a UAN, a unique authorization number. The patient is then transferred to the private hospital vendor where that's relevant. I mean, in some cases, they just go to the public hospital because they're not leaving the hospital, it's just that they're being treated within the system. And they're contacted and they're treated, they're admitted, they're treated and discharged. So they're treated, they get treated. Now, we're talking about in a lot of cases waiting list patients. So we're hitting the waiting list, the long waiters in the waiting list. The private vendor or the hospital will then send the discharge summary back. Now, in some cases, if it's done in sourcing, that's not relevant. But in outsourcing, it's incredibly important. We know what happened to the patient, that something was done to the patient. And the vendor submits a claim within the HSE claim system. So that claim says, this is what happened to the patient. This is separate to the discharge summary. This is what happened to the patient. They're filling in the information we need, not the information they want to put into a discharge summary. And the claims management system will adjudicate the claim. In some cases, as I said, it'll just be adjudicated. It'll just go straight through. But in other cases, we have to check it. And then it's paid using IFMS. So just some more detail on that. Like in most cases, the patients are being selected from the waiting list, and they're usually long waiters. At the moment, it's 180 days they have to be on the waiting list. But it has changed, and it will change from time to time. But the system is flexible. We can target individual things. Like so CHI patients, for example, are down to 0 days. So they don't have to be long on the waiting list. And then there's other specific rules around medical beds. Like patients aren't just being sent for medical beds. There are specific rules about what types of patients can be sent for medical beds as well. We create a record in the Access to Care portal, and they all get unique authorization numbers, as I said. In some cases, we have this bulk update system. If we know there's a group of patients going to the same vendor, We're not asking the actual hospital to type them in one at a time. We have a way of bulk updating from an actual Excel spreadsheet. And the different types of referrals that we have, I'll be going through them in a second, what they are, the different types of referrals, we collect different data points for them. So we have different pieces of information we're interested in, if it's the surgical services, if it's assisted human reproduction, things like that. They're treated, transferred, admitted, discharged, whatever it is, and we get a discharge summary from them, and it's key. It's key for waiting lists because the patient cannot be taken off the waiting list until there's proof that they were treated and it's been done. And then for outsourcing, like if it's going to an external hospital, the actual documentation is being sent from the public hospital to the private hospital. That's external to the system because it's important that there's a relationship between the public hospital and private hospital for the patient. In terms of claim submission, each one that's outsourced, you have a separate claim. And it's just like, from a private hospital's point of view, it's just like VHI claims, BUPA claims, all the health insurance claims that they deal with. And it has two components. There's a form and there's an invoice. We need an invoice and we need a form. And the invoice is for the payment. And the details of what we claim, what's in the claim is different depending on the referral type. Because in some cases, if it's just outpatients, we don't collect as much information. And once again, we're back to flexibility again. Flexibility, central to the system, because we're allowing for outliers. We know that patients will be sent over for a simple procedure and then something will go wrong and they're in hospital for longer. And the private hospital isn't out of pocket because of that. They can change the form. They can say, actually, the patient needed this instead or needed this in addition to what they had, and it costs more money, and we'll look at it. If it makes sense, we accept it. Most claims are adjudicated in the claims adjudication, but some have to be considered individually, and they're the outliers. We just look at them and see, well, why are they charging us twice what we expected? And we have a look and see. And so we either go back to them and say, well, look, explain more. But they know themselves, and they know because they're dealing with VHI, they know they're dealing with BUPA. They know themselves the reasons why, like if the patient is longer than expected, if it costs more than expected, they know we're going to be asked this question. So they'll often provide the information already. Without us asking, they'll say, this patient was in longer because they got an infection and they had to spend an extra 10 days in hospital. And then the claims reimbursement, and we have been working, we've had to change this because IFMS then came along in the middle of the project. But all the vendors are set up using the standard HSE process. That is quite a task, and it's correctly and very strict. I mean, when you're setting up vendors, it's correctly very strict, but individually it can be quite a task to do that. And then, one of my colleagues who's actually unfortunately not here at the moment, she's been very helpful in dealing with that. So I do appreciate the work that GOSHA does on that. The payments have to be confirmed. HPO aren't the budget holders of any of this. We're just providing the service, the software for this. So there's budget holders in the HSE acutes or in the National Women's and Infants Programme that are the budget holder, and they're the people who have to sign off. So they say, yes, these patients have to go and they have to do some checking on it. And then we make the payments directly IFMS. They go electronically. No brown bags full of cash or anything like that. It's just all electronic. And everything is subject to audit as well. And we have already, a couple of the actual payments have been actually requested from internal audit to be checked. So it is subject to audit, and it's all checked. And our colleagues on HSE acutes have gone through internal audit with it to check all the process. So just talking about the different types of referrals that we've got set up at the moment. We have surgical services. This is inpatient and day case services sent out to private hospitals primarily. It's typically all outsourcing. So you're talking about patients who are on waiting list for 6 months, or sometimes shorter, sometimes longer, longer patients for at least 6 months, and they're being sent out to a private hospital to have the team treated, whatever they're on the waiting list for. We have outpatients. We have that set up for a series of specialties. We have medical beds. So this is patients who will be sent over to a private hospital, but not for a procedure, just for medical beds. And this is, as I said earlier on, it's incredibly important for the winter initiative because it helped provide additional capacity for the public hospitals. I've spoken about the assisted human reproduction. There's been sent to private vendors for specific procedures. And then we have this thing called recurrent funding, which is kind of a catch-all for a whole pile of different initiatives, funding initiatives that are being operated by HSE Acutes that are targeting individual hospitals for individual waiting list things. So just more detail on that. So surgical services, we treat patients from the waiting list 180 days, as I mentioned. They're referred to the private hospital for day case and inpatients. And what that means is that the patient is being sent over to the private hospital, the documentation is being sent over to the private hospital, and the private hospital then starts treating the patient and treats them. And they treat them, and the patient is discharged by the private hospital, and it goes back to the public hospital, and it continues on from there. So it's not that the care is being transferred to the private hospital, it's just for that treatment. And we have over 2,000 products or procedures that people can be sent for. They're all procured. We've gone to the private hospital and said, well, look, tell us how much it would cost for this procedure, and they've given us a price. For the outpatient stuff, patients are referred from the outpatient waiting list. That's why we have the second waiting list. And it can be referred for more than one of 8 products. We have 8 products like to do with for different specialties, children and adult ones. So we have different specialties like dermatology, ophthalmology, plastic surgery, and neurology. And the private hospital claim form, we've had to change it for outpatients. So rather than having this more generic form where they just tell us what procedures are performed, because it could be any procedure, we know in this outpatient's procurement arrangement that they're going for these specific procedures. So we change the form so they can tick which procedures they got. And it will so that we know if they've ticked A, B, C, and D, then we know the value will be, and it can go through automatically. For medical beds, so patients being referred for medical bed services in private hospitals, right? So it's very important, very useful to provide additional capacity. And David just mentioned earlier on some of the insourcing and outsourcing they're doing in UL, and all the hospitals are doing it. So the selection of patients is very, very crucial in this, and there are strict rules. I mean, we're not allowed to send over patients who have COVID or who have flu or anything like that. Like, they have to be okay. Then there's no expectation that the patient is going to be sent over for a procedure. Now, patients may get a procedure, but they're not being sent over for a procedure. But if something goes wrong, they'll be treated. And in the past, though, it's not being done now, but in the past, the patients have been sent over for urgent and time-sensitive procedures. So it's also provided capacity in that case, but that's not happening anymore. For assisted human reproduction, patients are referred for one of 7 products that we have. And in the case, once again, the claim form, we've changed the claim form so that we understand what procedure they got, and so we can understand which ones are what the value of each claim will be, and we'll have better understanding of that. Just this non-recurrent thing, as I said to you, it's very much a catch-all. So it's a series of kind of funding initiatives, and at the moment it's being managed by HSE Acutes with assistance from the EY people as well. It's been in place for a number of years. Now, we're moving it into access to care to have better, improved reporting on it, because the reporting on it at the moment isn't great. We have overall numbers. We don't know what patients are being treated in this. So we're hoping to get better reporting. A lot of the outsourcing initiatives are essentially being moved into surgical services. We're actually making them surgical services rather than the way they're being done at the moment. And the insourcing is going to be bulk uploaded. Insourcing, again, is happening in the hospital. There are no claims when it's insourcing because it's not going to an external provider. So the claim will be, if it's inpatients, it's going to be HIPE, and if it's something else, it'll be some other reporting system. Just some images then of what it looks like. This is the Access to Care portal. This is what the public hospitals see, so they can submit cases, and the most important button there is the Add button. But you can see on the left-hand side, you can see where it says outpatients, and it has NREC, and it has NREC short for non-recurrent, and has medical beds. And so they're the different options, the different referrals. And the assisted human reproduction, it's just click on the Add and you get the option there as well. And there's an example of access to care, or what we call surgical services. Now, this system is called the Access to Care portal. It used to be called the UAN portal, but we decided to call it the Access to Care portal. So you can see the types of information we're collecting. Nothing chaotic. Isn't a major amount of information being collected here. And that's what we're getting back to again, the ease of use idea. So I just filled in one there just to give you an idea what it looks like. And once you fill it in, it then tells you what private hospitals are available for the product that you've chosen for your public hospital. We have the facility to bulk upload. So as I said to you, if we know we're sending a whole pile of patients for one thing to one vendor, rather than get somebody in the hospital, type them in individually, we can bulk upload them. From a claims point of view, then what we can do is we can see the claim system, and this is what the private hospitals use to submit their claims. So what you can see is the UANs. I blanked them out there. They click on open to submit the claim, and you can upload the invoice as well with the invoice button. And just to give you an example of the types of information we're collecting in the surgical services, not excessive again. We're just collecting information so we understand when the patient was in, what happened to the patient, some details about the patient as well. In the case of outpatients, I said to you, we had to change the actual outpatient screen so that we know individual procedures that are performed for outpatients. So you can see, so if a different type of outpatient is there, then a different list of procedures are shown. So it's very flexible from that point of view. And similarly for AHR, you can see the different types of procedures that can be performed. Reporting is central to the system, and it takes up a lot of our time to do reporting. But it is really the big win from the system, because collecting all this information and being able to do all the stuff like auditing and reviewing of all the data, that helps us with this. So you can see some of the reports. There's a whole pile of reports that come up. Every morning at 7 o'clock, I get about 10 emails because I get copied on all the reports. And you can see the types of reports we're giving. We're giving full day reports, full daily reports on all the UANs sent to any hospital. We can see like warning reports and budgets. We have budgets across all this stuff, so no hospital can go bananas and send piles and piles of patients. We have budgets on it. We have kind of overview reports. We have weekly reports. So this reporting thing is making sure everybody understands what's happening, what's going through the system. Just some results we have for those things. So you can see across the top we have surgical services, outpatients, AHR, medical beds, and non-recurrent. And you can see that the UANs start with different letters so we can be clear, we can understand which one is which. The number of referrals for surgical services and across the whole island is, like so far over the whole system, is 9,554 cases. Outpatients 3,055, AHR 625, medical beds 3,507, and non-recurrent 299. Non-recurrent is the current one we're working on at the moment. And you can see some of the other things as well. And so what you're also seeing is the number of claims, and this is a little bit less because there's some claims that haven't gone near the private hospital yet; they're in process, or some that have gone through the private hospital but they haven't actually been claimed for yet. So what you see is a slight reduction in claims. You see 5,891 for surgical services, 278 for outpatients, etc. And you can see the value, and that's in thousands. Overall, we've spent nearly 57 million on surgical services. So that's 57 million spent on patients being taken off the waiting list and clearing the waiting list. And they're the long waiters as well. They're the ones we really want to try and get off the waiting list. And it just gives you the number of referring hospitals there at the bottom. Now, just make the point again, just in terms of non-recurrent, if I'm giving this presentation this time next year, which I probably will be, but if I'm giving this presentation this time next year, the non-recurrent one will be as high as all the rest of them. The non-recurrent one is the newest one, so that's why it's low at the moment. And just to give you an idea then about what the referrals by month, I've gone back to the start and gone through it all, referrals by month. You can see it. It's been gradually building up. The blue line is the surgical services, and the rest of them are more recent. They've been added. You'll see a dip there around August last year, and what happened is we changed the framework. We had to go back and redo the procurement. So what happens is that there was a drop because we knew the old one was coming along. Thanks, Jackie. The old one was coming to its end, and the hospitals knew the new one was coming. The public hospitals knew the new one was coming, and there'll be an expanded set of procedures. So they stopped sending patients because they're going to wait for the new one. Just some challenges then, and I am coming to the end of this, just some challenges then. So the first thing that we've realized, I suppose, and it's easy for me to say this from a public hospitals point of view, is that the business models between private hospitals and public hospitals differ significantly. And I'm trying to be as polite as possible, but there are significant differences. One of the biggest issues we've come across is staff turnover issues. Like, there are occasions in Hype where we've dealt with the same coder in a hospital for 20 years. But sometimes in a private hospital, we would ring up a month later and the person we were talking to is gone. Like, it doesn't happen in a public hospital. So that's something we need to factor in. Connection issues is an issue. Some of the actual hospitals are connected to the National Hospital Network, but others aren't. And so we've had to deal with that. And that takes up a lot of our time, with a lot of the lads' time, because those connection issues can be a problem. People are connecting using Citrix. And then timely data is a significant problem. One of the things we found with the private hospitals is that private hospitals have to have a requirement to provide this. There needs to be a benefit to them to require it, to provide this information. It has to hit their bottom line. And so, even though these are claims, it still seems to take a while for them to submit this data. The other thing we've seen, the challenge, is that the database and system has evolved as we've gone along, right? And there's an element of we're fixing the plane while we're flying through the air. And it is kind of a bit kind of scary when we're doing that. So we just need to have to be careful with it. And there's probably an element that I need to apologize to my colleagues that some of the things I come back with, they kind of say, oh my God, how are we going to do that, right? And then the controls around the vendors are very strict. And that's expected. I mean, vendor fraud is a big thing, and we have to be very careful about it. But it means that it causes delays, and the private hospitals, they don't understand why the delays are there. They just want to get paid. But sometimes we have to go back repeatedly to private hospitals and say, well, actually, no, now we need you to fill out the form again with something different. And as I mentioned, my colleague Gosha, who unfortunately can't be here today, she has been very helpful for doing all that. Just thinking about the future, as I said, this whole non-recurrent thing is where we're going. It's a work in progress, and this is what we'll be working on in the next couple of months, where we're moving this stuff that has been collected in a kind of fairly haphazard way, and it's going to be very detailed. It is important for us. A lot of the stuff is insourcing, and what we need to do is we need to see it. We know what's happening in the hospitals, and we'll be able to get an idea of who it is and how much it is. So we'll be completing that over the next while, where we will be onboarding hospitals. We started with one set of hospitals, and we're moving on to the next set of hospitals. And it's going to lead us to additional reporting and enhanced data, because once we start collecting that, that's going to be extremely useful for other aspects of our work. The existing procurement frameworks, they don't exist forever. They have to be changed. They have to be updated from time to time. They have strict time limits, so that's going to happen. The frameworks, the surgical services one, will have to be updated later this year. And that will lead to new products and new services. That means updating the whole system. The old ones no longer are there. We now have to come up with new ones. And then there's going to be general enhancements to the system. Now, we think we're close to the final system, but I think I'd be very foolish to actually put my hand on my heart and say that's going to happen. So then, just in conclusion, look, the systems have continued to evolve over the last while to meet the needs of HSE acutes and other partners. So, I mean, what we've managed to do is take the system and evolve it, and so we meet the needs of the other partners. We've had new referrals types, as I've outlined. We've had new features. We've put in new systems as well to actually deal with all this evolution of requirements. My expectation is that the evolution will continue while we keep the core functionality of allowing patients to be referred, admitted, treated, discharged, and paid for. That's our central goal of doing this. That's what we're trying to do with the system. But we will continue to evolve the system while doing that. Thank you very much.